Hello, my name's Alistair McCall, and I'm delighted to be hosting this latest in a series of NR Times roundtable discussions. And today we're focusing on the subject of stroke rehab and meeting the various needs of all those involved in that rehab community. I'm really pleased to say we've got a fabulous group of panelists with us today who are going to be very generous, I'm sure, with their insight and their views. So I'm going to ask each of the panelists just to say a few words to kick off our discussion about themselves, their organisations, and their areas of specific interest. So if I could start with Jemma and Zoe from QEF. Jemma, do you want to kick off?
Yeah, so my name's Jemma. I'm a senior neurophysio. And
I'm Zoe. I'm also a senior neurophysiotherapist, and we work at QEF Care and Rehabilitation Centre in Surrey, seeing clients really from subacute to long term.
Great, thanks, Jemma. Thanks, Zoe. Marlon?
Hello, everyone. My name is Marlon Shepard. I am a stroke specialist or neurospecialist, occupational therapist, excuse me. My primary experience is working with patients from a hyperacute setting to a community rehab setting. I'm currently working at Avonfield Neurological Center. It is based in Northamptonshire, and we're a brand new service offering a bespoke rehab pathway for individuals who suffered strokes, ABI, TBI, and other neurological conditions. We're currently providing a rehab pathway for one ICB, where we've integrated the pathway with their acute and community provision. So we're quite excited about that. Avonfield in itself is part of a larger organization called Elysium Neurological, which provides hospital and residential services for people with a wide range of neurological conditions, including stroke.
Great. Thanks for that, Marlon. And Paul?
Hello, Paul Taylor. I'm a clinical scientist and also clinical director of Odstock Medical. Odstock Medical is an NHS-owned company set up by Salisbury District Hospital to develop and provide functional electrical stimulation services around the country, and also a little bit internationally as well. So we make kit, we provide clinical service, and we provide training for clinicians.
Great, thanks very much, Paul. If we could start off our discussion by going round the panel and hearing various views and opinions of our panelists with reference to what excellence in meeting the needs of individuals and families strokes and going through the rehab process. Jemma and Zoe, if I could start with you, if you could say a little bit about what you think excellence in support and rehab looks like.
Yeah. So I think a lot of it is around sort of being patient-centred and sort of thinking what their goals are and what they would like to achieve. I think we spoke briefly about this before joining the meeting. I think the guidelines, the national guidelines for stroke rehab, set out quite nicely, like quite a nice level of what we should be providing for every patient as well. So I think sort of following that pathway and making sure that we are sticking to everything being about what the patient wants and focusing very much on their goals, that we can sort of work towards making our care more excellent as well. Sorry.
I think in addition to that, excellence is almost got sort of three prongs to it. There is, of course, the service that's being provided, and that's, like Jemma said, outlined by some fantastic guidelines that give us a really good gold standard approach of what we should be delivering. But also, in addition to that, you have outcome. That really we need to be getting good outcomes, or the best possible outcome for our clients, and we need to be able to measure it, we need to be able to prove it and evidence what we're doing and how we're getting there. And then finally, it's about experience for the client. So we want our clients to have a positive experience, we want them to have a meaningful outcome, whatever that is for them, so that their life still feels relevant, able in whatever manner they're kind of in. And so it's multifactorial, really, that service is not just about what we deliver, it's about how are we doing it, what results are we getting, and what does our patient think?
Great, thanks Gemma, thanks Zoe. Marlon?
Yeah, no, I want to piggyback exactly what Gemma and Zoe were saying. They're referencing the guidelines from the National Institute for Health and Care Excellence. Obviously, it has excellence in the name. Now, when you look at that, anyone can access it. It's on the internet. It says 3 hours a day minimum for 5 days a week minimum. I think that that's certainly a standard to strive for. Do I think it's happening regularly? Not necessarily the case. There is the SNAP, or the Sentinel Stroke National Audit Program, which is obviously collecting data around this. Again, anyone can access that and have a view of whether they see, or what they see is what I'm saying, which is the fact that it's not necessarily always happening. So I think that's a struggle that the NHS and just therapy providers around the UK are recognizing. And this is really down to not having enough of the correct people required in full MDT. So PT, OT, SLT, speech and language therapist, that would be. There's not enough of us. Orthoptists, psychologists, neuropsychologists, there's not enough of them. They're very rarely involved in MDT to begin with. So I think it's about recognizing what the excellent standard is, which we know because it's outlined, but then it's actually striving as a service to actually achieve that, which I think is rarely happening. And that's because we don't have enough of the actual professionals required. Um, Before I came to the UK, there was a bursary for people who wanted to study occupational therapy. So they didn't actually incur any student debt. They had the same sort of thing for nursing. That has since ended. Now, obviously, I recognize that there's powers that be that control all of this stuff. But I think that a lot of the reason around why people aren't necessarily going into healthcare, which is why we have such a lack of staff, is because they are recognizing that you go into a workplace, it's really challenging. It's, you commit so much of yourself to it, but then there's student debt and other things. So I think it's really about trying to sell the idea of doing this job, because I think it's an incredible job that we do and we get to achieve great outcomes, much like Gemma and Zoe were saying. But it's about making sure that the young ones coming up are actually recognizing that.
Great, thanks, Marlon. And we'll definitely come back to some of those challenges that you mentioned later in the discussion. And hopefully some of the powers that you be will be listening to this, and we'll hear some of those messages. Paul, from your point of view, the characteristics of excellence?
Well, it's hard to know what to add to what's already been said. Certainly the problems that we see is lack of provision of rehabilitation, and often it's not done in a timely manner. So I would add to what Gemma and Joey said, that the importance of timely intervention, providing services when the patients need it. Too often we see things like Botox services for spasticity rationed to a point where the patient only gets a fraction of the amount of treatment they need, and this means effectively they're not getting the benefit that they should be getting. Yes, I don't think I have anything else to add.
Okay, thanks for that, Paul. Both Paul and Marlon touched on some of the challenges faced by providers and professionals in making sure that excellence is delivered consistently. Can we spend a bit of time just talking about those challenges? Marlon, you mentioned recruitment and attracting and keeping the best possible talent. There must be other challenges as well. Can I just open it up to the panel to talk a little bit more about some of the challenges that we face? Zoe.
I think from a challenges perspective, you can divide them up into different, almost like headlines. You've got, like you sent in the accompanying information, sort of the professional's perspective, but also the rehab provider's perspective. So just to start from a professional's perspective and carrying the similar theme that Marlon brought up when he spoke previously, was about recruitment. I think even prior to recruitment on the floor work, one of the hardest challenges we face is about delivering the intensity to the clients of what's expected. So we are a rehab unit where people are residential with us, and we are constantly trying to problem solve and plan how we can make our client's day as active and as meaningful as possible. And there are lots of different ways of doing this. Some of the things that we have put in place, like innovative group work. So they have one-to-one sessions. They also have group sessions. We've also just started a close support group, which is where people come to the gym with their own independent exercise program, and they have the opportunity to use the gym independently with just one therapist supervising. So we're getting large client numbers to low numbers of qualified staff ratio. And it's really sort of trying to think about ways that we can deliver the intensity with the staff that we have and the recruitment pressures that we face, how we still deliver that on the floor. And I'd be really interested to see what the other guys think in terms of what they've done to try and meet that need, really.
Marlon?
Hello. So, thank you for that, Zoe. I completely agree with what you were saying. Therapist to client ratio, it's difficult to achieve. And something that I've really kind of put a lot of energy in, and I know something that Elysium really backs, is upskilling staff. So we recognize that, there are not enough qualified therapists. That's understood. But what we then need to think about is how to tackle that. Now, obviously, recruitment takes years. But what we really need to think about is identifying the people that are already in healthcare. So that's rehab assistants, that's care workers, that's nurses, that's care assistants, um, and upskilling them to be able to really participate in the rehab process. Rehab should really ideally be, especially for an inpatient setting, a 24-hour endeavor. And that, goes from everything from adequate sleep hygiene and good nutrition and hydration, etc., all the way up to doing actual dynamic work with physios and OTs, functional work with therapists that really focus on, like Zoe and Gemma said earlier, what the client wants. But when the therapists aren't present, other people need to be skilled and confident, and obviously taking up the mantle of continuing that work that we're already putting in place. So I think that there needs to be a lot more focus on that from providers all around. And it's just about knowing that it'll take time, it'll take effort, but I think at the end of the day, the juice will be worth the squeeze, because you'll get a lot more qualified, well, not qualified, but competent and capable individuals to carry on that good therapeutic work.
Paul?
Yeah, I would definitely like to support that, what you just said. Our approach, we use technology, electrical stimulation therapies, and these are very much designed so that people can use them at home with arm's reach supervision. Part of that is training certainly the patient, but also their carers, family members, to support the patient. So it's very much trying to empower them to be able to continue with therapy without the direct support. I would say this tends to be further down the rehab pathway when people have left the hospital treatment. But yes, empowering the patient to do as much as they can themselves, I think, is important.
Thanks, Paul. Marlon, did you want to come back in?
Yeah, if you don't mind, something that we're talking about, or at least primarily talking about from my perspective, an inpatient setting. So you leave a hyperacute setting, hospital that would be, and then go into a rehab community setting where you're in a building filled with therapists, much like it sounds like Gemma and Zoe work in. But something that we haven't really touched on is actual community services. So community people living in their homes, much like Paul was talking about, and then receiving services at their residence or nearby to help them improve with their recovery. Now we have something called community stroke teams or early supported discharge teams, all of which are very useful and used nationwide. But something that, obviously, going back to excellence in the NICE guidelines, National Institute for Health and Care Excellence, it says that early supported discharge teams should really aim to endeavor to give the same amount of intensity of therapy as they're receiving as an inpatient. Now, I can almost guarantee that that's not happening. You would have to have massive teams with many resources to be able to achieve that. And I obviously live in Northamptonshire. I used to work in a acute setting, and we have a community stroke therapy team, and their team is indeed enormous, and they do some fantastic work, but they are stretched, and they, much like myself, are really focused on upskilling as many people as possible, and that includes family members, to be able to carry on the good work that's being done elsewhere by the professionals. So I think a major challenge is not only thinking about the inpatient rehab setting, but also the community rehab setting, as in the home.
Zoe, I think you wanted to come in there.
Yeah, just to add to that. So I would say the first professional challenge that we talked about was delivering intensity. And I think Paul almost started on the second one, which is about transitioning between different teams and different services, particularly at the point of discharge. So we work in rehab, we then discharge into the community, but often they'll leave with referrals in orthotics, spasticity, electrical stimulation services. You've got a client that's almost got a web of a network around them. And I think almost certainly at our organisation, we're trying to problem solve as many of those issues before people go. So there's no kicking the can down the road with the community team. We do as much of it as we can in-house so that it's as seamless as possible to transition into the community. But certainly that is a challenge, the communication between teams, the networking between teams, trying to make sure that the discharge is as seamless as possible. It is a challenge.
I'm sort of surprised that nobody's mentioned funding yet. But Paul, you wanted to come in. I think we've skirted around it. I'm not necessarily asking you to pick up the subject of funding, Paul. I think you wanted to come in anyway.
The point I was just following on from Zoe was the need for long-term continuing care, particularly when it's around providing devices. These need to be maintained and configured to the person's needs as they change. And a lot of our rehab services in the NHS are relatively short-term, acute, subacute, early supported discharge. There is a bit of a hole where it comes to the long-term support. And again, that's something that we try and provide in our clinical services. Funding is a perennial battle, and we spend a lot of time putting in individual funding requests, and the situation on funding varies from location to location. I've often said the NHS is silent because there doesn't seem to be national policies or policies which are not adopted locally. So it is a perennial problem. In terms of FES services, I would say funding is improving as the evidence is built, as it's entered into the national guidelines, as it's been supported by bodies such as the Association of Physiotherapists in Neurology in their recently published guidelines on use of FES for lower limb walking. It's a slowly improving picture, but there's a lot more needs to happen yet.
Is awareness a big issue? And I mention awareness with reference to access to services for people requiring support, but also awareness amongst legislators with reference to the size of the rehab community and those long-term needs that you talk about, Paul. Is awareness a big issue?
Absolutely, it is. The primary care services are not fully aware of what services are available, what can actually be offered to patients, it takes an awful long time for newer techniques to get into the guidelines. I mean, for example, at Salisbury District Hospital, we started our first FES service back in the late 90s, and it was 15 years before this, the service got mentioned in national guidelines and only fully brought into national guidelines in the last 2 years. It's such a slow, long-term problem getting new techniques into the wider rehab world.
Thanks, Paul. Zoe?
Just touching on that as well, Jemma and I were just, before we met, mentioned about expectation, that families and clients, patients don't understand that there's a finite resource, that it feels like it's something that it's never ending. So you have paid care and healthcare for for an extended period of time, and that understanding that it will come to an end is something that's quite a big challenge.
Yeah, and I think also because we accept patients from quite a few boroughs within London and different ICBs, they don't all offer the same community services as well. And it's quite tricky when our clients are sort of all sitting together and talking about their plans for home, and then they then come to us and say, well, this person's having this, and why aren't we getting that? I think that ties in with the funding as well. And it's just, it varies so differently for us and our patients that we discharge. And yeah, it's just quite difficult to then manage those expectations, because they do build relationships with each other here, and they do obviously speak. And it's a challenge, because not every area offers the same services. And it's just hard to then get them to understand, and then to get them to sort of understand where they're going next and what is available to them. And then the challenges that we face with that as well, we have to think when we're discharging our clients, can we discharge them any sooner, or do we have the services available in their area? So it all comes into the funding as well, depending on where they're from. And that's sort of where the challenges come in as well. And then that also ties in with the first question about excellence, because it's so variable that even though there are these guidelines in place and there are these expectations that we all should be meeting, it's quite difficult when the funding isn't in place within all of these areas for us to then meet those expectations set out as well. Yeah.
I think a clinical example as well is that we would refer into like an orthotics clinic, which if someone's with us for 12 weeks, there might be a 4-month waiting list to see an orthotist. So they're unable, we will do what we can do to our best of our ability here, but we might not be able to get the orthosis for them to take away, for example, when they leave us. And that's where the mismatch is. They're getting a very, very expensive period of paid rehab, but the services aren't all in line because they're all different sort of independent organisations, that we can't get what we always need in order to then make the best possible of their period of time with us. I think it touches on what Paul was saying about with his FES.
It is clear with reference to the postcode lottery nature of some of the provision, as well as that complex picture, that navigating it must be quite demanding. You mentioned families, Zoe. The challenge for families and those close to people involved in rehab must be incredibly demanding.
It's been mentioned already, and I think it's something that really needs to start from day one, which is about self-management, but also family engagement or carer engagement and support. Because like what Marlon was saying about upskilling the MDT, we also need to upskill the client and the family so that everybody's aware of what needs to be done, how to best manage their condition. And I guess a lot of it depends on individuals as well. There are some people who get it, there are some people who don't, but the expectation is that, treatment is, not limited, whereas we very much know that it is, and you get funded for periods of time, and that rehab must come to an end at some point. Even if you transition onto another team, into a community, into outpatients, certainly inpatient rehab doesn't last forever.
Yeah, thanks, Zoe. Marlon?
Yeah, I just wanted to touch on what Zoe was saying and what you brought up, Alistair, which was, families and the struggles that they experience um, being caring for someone who they love who's suffered a stroke. And when you brought up the word awareness, I think it's also very important to obviously have awareness of what services are out there and the difficulties, etc., but also have an in-depth awareness of what is actually happening for the person who's experienced the stroke. So that's both families and the individual, so you should actively take time, and when I say you, I mean the wider MDT. Take time to educate the family, to educate the person who suffered the stroke around what's happened, why this could have happened, the different types of symptoms that they're going to experience. And obviously, we all recognize that a stroke happens in the brain and that brain affects cognition. And so, this is something that you may touch on it once, but the reality is that you need to touch it on it again and again and again. Repetition is key. I'm sure the physios will be able to say the same thing. And the same thing goes for the families, because when you're grieving, I'm sure we've all been privy to or experienced ourselves. When you're grieving and you have heightened anxiety, your own cognition is impaired. So someone will be telling you information, but you're not really taking it in. So again, you need to revisit it with the family again and again and again. And ideally, with this level of knowledge and this understanding about what's happening for the individual, the family can then really conceptualize what it means to be as a person who's inpatient in rehab, knowing that it's a finite resource, and that eventually the person will be exiting rehab and then going somewhere, ideally home if we can make that happen, and then recognizing that environment, that lifestyle that they used to have is about to change. And then it's about supporting them through that recognition and their understanding, equipment provision, carers. There's a whole gamut of things that happen for an individual when they leave a hospital and they go home that the family are kind of told about, but they're not really educated in. And that I think is a shock. And then when that shock happens, the family don't really understand and know what to do. And it makes the experience for the person who suffered the stroke all the worse. And so really behooves us as an MDT not only to think about what we can do inpatient, but also really about making sure that everyone is talking and singing from the same hymn sheet in regards to what life is going to be like post rehab.
Great, thanks, Marlon. Zoe?
Just to add to that, we found the expectation management in our organisation quite tricky, particularly with discharge planning, and touching what Jem said about the inconsistencies about different boroughs offering different services, and we work with lots of different boroughs, is we introduced a letter that we provide to the client as they arrive. And in that, it stipulates who's funding their care and how long they're funded for and what their discharge date is. And they get that on arrival. And it's almost like they've got it as a piece of paper so that they understand exactly what is being provided when they come to us. And that certainly helped in terms of you can then reference that at subsequent meetings. And that's been quite useful, actually.
Thanks, Zoe. Marlon, did you want to come back in?
Well, I was just going to piggyback on what Zoe said. We here at Elysium and at Avonfield are about to implement the very same sort of thing. So great minds think alike.
If we can move on now from some of those challenges, and we've touched on innovative approaches, but can we focus on new developments, innovation, new approaches that promise an even brighter future for the rehab community? And if anybody wants to give examples, that would be great as well. So innovation and new approaches. Marlon.
Sorry for raising my hand so much, but I've been very lucky and fortunate to be a part of an innovative program that's actually being rolled out here in Northamptonshire, and it's something that has NHS England funding. It's something that is being researched and documented and supported with all the various quality improvement organizations. But what's been done is obviously considering the fact that when someone suffers a stroke, it's a loss. They're losing a part of themselves. They've had damage, and that again, like touched on before, is that's a grieving experience. Now we all recognize that there are members of the MDT, like I touched on earlier, that aren't really as present as would be required for genuine benefit of the clients or patients, and that's neuropsychologists and psychologists in general. They're essentially gold dust in the NHS. And so what is something that we've done here in the Northamptonshire Community Stroke Rehab team is actually implementing a level 2 health and wellness coaching program. And it's a 18-month program where therapists and rehab assistants and nurses involved in stroke care in the community are actually learning from qualified therapists, as in, psychologists, about how to become level 2 health and wellness coaches. And when you have that training, which I've taken, it's been very, very beneficial for me. It's really helping you understand as a clinician about a holistic approach towards helping a person who suffered a stroke actually manage their expectations, but also maintain motivation. Now, motivation is something that is integral to therapy, all kinds of therapy. You need to want to do it. You need to want to improve. And it's about, like Zoe said earlier, goal setting, etc. A lot of the time it's, yes, patient focused, etc., but we are, or at least what I find, we are too focused on trying to get done what needs to be done. You need to be able to wash yourself. You need to make sure that you're able to sit in a chair until the carers arrive, etc. But we're not really focusing on what is the motivating factor for the individual. And having this level 2 coaching program that I've completed, it really helps you recognize that when someone's grieving, you really want to tap into something that they are actually really keen to do. It doesn't matter how ludicrous or out far afield it seems like it might be. If it's something that's going to put the fire in their belly to do therapy, go with it. So it's something that has been being done right now, and it's something that I'm hoping is going to get rolled out for more services nationwide.
That's a great example, Marlon. Anybody else on innovation, new approaches? Zoe?
I think, sort of referencing back, so we spoke at the beginning about what is excellence in stroke rehab. We first of all referenced the guidelines and then talked about outcome. And I think in terms of what we're doing here, we have a relatively recent purchase of a Tyromotion machine. So in using that, we're trying to get better data about our clients so we can better assess, record, and then hopefully treat as a consequence. So starting to use some newer tech devices to try and help us with that. But I suppose the overarching feeling is about, with doing that, we're then going to better understand what our outcomes are.
Paul, Zoe mentioned technology there. Is technology having a big impact on innovation and the future for the stroke rehab community?
It has potential. Very much the drive is to try and use technology to try and stretch the resources that the team has. So enabling the clinician, the therapist, to provide more therapy per unit therapist, as it were. So the recent change in the guidelines has started recommending the use of electrical stimulation, and one thing which I think is important is recognizing the role of electrical stimulation in reducing post-stroke pain, in particular shoulder subluxation pain. And in my own clinical practice, I've seen some really sort of significant life-changing effects, eliminating or almost eliminating quite serious neuropathic pain just by a fairly simple exercise routine with electrical stimulation. The other movement is to try and retrain functional movements by supporting it with muscle stimulation, timing stimulation to the patient's attempts to do a movement, and consequently that's reinforcing the neuroplasticity and hopefully getting a bigger effect for the patient. And as I said previously, trying to do this in a way that can be done with minimal continual assessment from the clinician, obviously involving them in the setup of the device and the prescription of it, but then allowing the patient to use it at home to their own benefit.
Great, thanks, Paul. Marlon, and then I'll come back to Zoe.
Just touching on what Paul and Zoe have already said, technology is massive. Obviously, technology is improving worldwide all the time. So, Tyro Motion, things like Mind Maze, Phesia Grasp, functional electronic FES bikes, functional electronical stimulation bikes, excuse me. There's a ton of equipment out there that's I've been lucky enough to use with patients and see fantastic outcomes. Now, obviously, we touched on the subject of funding before. Now, funding obviously is the major driver behind having technological innovation. And so, if we're unable to recruit, if we're unable to get qualified staff in the doors, then exactly what Paul was saying is per unit therapist, if we have more tools available to us that we can then set up and calibrate to a particular patient to have therapy with someone who's non-qualified but able to use that piece of equipment, then obviously that helps the outcomes and obviously their overall productivity of the therapy provided. So I think being able to have things like technology is massive, but also that follows on to things like telehealth. So being able to have an individual have a functional electrical stimulation machine at home, having a therapist on a screen similar like we are right now, and actually going through the process of having them use this machine along with something like a saboflex if someone's got hemiplegia of the upper limb, to be able to actually help them learn to do functional work without you physically by their side. So really trying to use all these other tools around us to really help obviously improve the care that we provide.
Yeah, thanks, Marlon. That's a great point. You know, technology is a tool to increase access to services as well. Uh, Zoe, glad to see that you and Jemma are still with us, and it was only a drill. You were interrupted by the alarm.
I was just saying that in terms of treatment approaches, trying to be really forward thinking about collaborating across the MDT. For example, physiotherapy with neurologic music therapy. Certainly, we've had some nice results with clients who may have a perceived plateau, or I suppose in more loose terms, might have hit a wall. And then you realize you can actually go beyond that when you start to collaborate across different specialities. And that's been really effective as well.
Thanks, Zoe. We're sort of starting to head towards a conclusion to this discussion, but before we sort of draw things towards that conclusion, can I ask if there's anything that we haven't covered that anybody would like to address? Marlon.
Sorry. Something that I think isn't addressed enough, and something that I think would be useful for this panel to, broach the subject upon, is the fact that having a holistic approach around a person is equally as beneficial as addressing a very specific stroke symptom. So I touched on it a little bit earlier, but things like sleep, nutrition, hydration. These are things that we kind of just assume they're happening and that they're happening well. That's not necessarily the case. A lot of individuals who suffered strokes or ABI, TBI will have disturbed sleep. Now, sleep I consider to be our superpower. If we sleep well, then we can function well. If we don't sleep well, we massively struggle. I know all of us have had moments where we've just had really poor sleep the night before, and then the next day we're, a quarter of our capacity of performance. And so if you're already suffering in your performance because of something that you've experienced like a stroke, when you have disturbed sleep, it just compounds that. So we really need to think about looking at things way more than just saying, oh, you have a hemiplegic arm, we need to work on this, or, we really need to get weight bearing on that leg. It's about actually looking at the much bigger picture. And something that I think also is really, really important is leisure. Now, we always talk about getting people back to doing what they need to do, like I said earlier, but it's about also thinking about what people want to do. How are people going to spend their leisure time? They're going to have a lot more of it. They may not be returning to work. And so it's about actually implementing genuine therapies. So in the US, they have something called recreational therapy. It's a recognized therapeutic person of the MDT, much like SLT, physio, OT. It's not really broken ground here in the UK. It kind of just falls to occupational therapists or physios to kind of cover that terrain. But the reality is that this is a genuine therapy all on its own. And its whole purpose is really to identify how we are going to help this individual who's now changed return to enjoying life. Not experiencing life, but enjoying life, having a greater quality. And that is something that I am shouting from the rooftops, because at the end of the day, if someone's not returning to work for whatever reason, they have a lot of time on their hands. And how they use that time is really going to affect their overall outcome in how they're actually experiencing the rest of their days. So leisure is something that is absolutely paramount, and it's not something that we focus on nearly enough.
Brilliant. I'm glad you brought those points up, Marlon. I don't know if anybody else wants to come in the back of Marlon's comments there. No, points well made. I can see nodding heads, Marlon. And I suppose that holistic approach plays to something that some of the other panelists have mentioned, the need for that integrated care plan that encompasses all of those things that you mentioned and more. Just to sort of round off the discussion, it would be nice to look towards the future and just hear a few words from each of our panelists about your hopes for the future, and maybe those one or two things that you think would make a big difference to that stroke rehab community over the months and over the years ahead. And keeping in mind, Marlon, your point that I hope there will be legislators and decision makers listening to this as well. So it's a chance to say something to them about your hopes for the future and those maybe one or two big things that you think would make a big difference. So I'll go around the panel in the same order that we started in, and that means, unfortunately, Jemma, I'm going to come to you, Zoe, firstly. But it's fair if you go first. If you go last, then the things that you might want to mention.
Right, yeah, I don't have the next thing. My hope for the future would be everyone having the same access. So every community has the same level of support, everyone's offered the same opportunities to come for inpatient rehab, and that they all receive the same high level of care, that we all know that we are capable of delivering. Would be my biggest hope.
Brilliant. Zoe?
My hope for the future is about seamless communication between services and across services to improve client experience, but also therapist experience.
Thanks, Zoe. Marlon?
So something we talked about is obviously patient-centered goals. Now, we've all gone to university in terms of us as therapists, and we've talked about goals and setting SMART goals. But something that is not actually standardized is how we as a wider therapy team in the country, in the nation, go about actually discussing goals, setting goals, and then trying to attain goals. So my hope for the future is that there actually become a standardized protocol and actual method of doing this. And there's actually already something out there. It's called goal management training. This is something that's evolved from neuroscience research. It's got a massive amount of evidence behind it. And it's a cognitive rehab program, just much like cognitive behavioral therapy is. But the difference is that this is really focused on towards executive functioning, attention, and overall goal attainment, which, let's be honest, as rehab professionals, that's what our bread and butter is. It's about being able to set genuine goals from the patient and then actually using a standardized methodology in goal management training towards working towards achieving that as the MDT. I think that there's a lot of benefit from all of us actually attempting the same thing by doing the same thing, because otherwise it's very piecemeal. This person does it differently, that person does it differently, and then the goal isn't actually achieved. It's already approved in America by the American Occupational Therapy Association. It's a CPD course. It's something that I'm hoping to take quite soon. It's something that I hope one day is actually a part of the actual university program that therapists will be receiving here in the UK.
Great, thank you, Marlon. And Paul, you get the final word.
It's something that I think is starting to happen but needs to progress further. I think Rehab has been the Cinderella service compared to acute care, and in part because acute care is medic driven and Rehab is largely therapist driven. That balance needs to be changed so that more emphasis put on long-term rehabilitation services, which is the treatment that's going to get people back into the community, back into normal life. So I think the recent guidelines have started that process or kicked it along the road a bit further, but that would be my ambition for rehabilitation.
Great, thanks very much for that, Paul. And that concludes this NR Times discussion on meeting the needs of the stroke rehab community. On behalf of NR Times, I'd just like to thank all of our panelists who've been fantastic for being so generous with their time and their insight as well. For all those watching, thank you for watching. It's been a great discussion. So this will be available in the NR Times platform, also on YouTube. So please, it deserves to be shared as widely as possible and seen and engaged with by as many people as possible. So thank you again to our panelists, and tune in for the next NR Times roundtable in a few weeks' time. Thank you.